We have some folks online as well.
Okay, how many we got online?
3.
Oh, good. Okay. One already? Over here? Okay, welcome. We're back to our first session of the year. My name's Donna Metot, and I'm the chair of the HRM chapter. We meet the second Monday of each month, and as long as Todd's available, they will be webcast and archived. So I'm very pleased we have some people here right in Halifax, and we have some people online. Just before I begin, there's some housekeeping. Well, most of the people here are returnees. I think you know where the washrooms are. I don't think we won't be having our usual break tonight. So if you want a snack or a drink of water, just go get it when you're ready. And for those of you at home, I think you know to type in your questions, and we'll probably take the last half hour or so, or we might do it intermittently. I think it would be better to do it intermittently, the questions from home. I'll hand out the attendance and the evaluation sheets, which are very important. And for those folks who are at home, it would be great if you could add your comments at the end for us. So Todd, can you just pass that around? And okay. Okay, before we begin, I just want to mention the next couple of topics because I know I'm going to forget by the end of the session. Next month, October 20th, because of Thanksgiving, we won't be meeting until October 20th. Come on in, have a seat. And Dr. David Whitehorn is going to do a session on mindfulness, so that should be very interesting. The November session is a discussion of books, articles, and concerns. That one will not be webcast. Mindfulness will. Also, December 8th, we will be having current research in psychosis. That's with Dr. Phil Thibault. So that's the line up till Christmas. In January, we have Dr. Stephen Eyre, the Executive Director of the Schizophrenia Society, and he'll be speaking about the stigma of mental illness, the facts and the future. And I think that's just about it for housekeeping. So we'll get welcome. So we'll get started. It is my pleasure to introduce Dr. David Gardner. I got this off the website, David. I like this. You are a Scot in Canadian clothes. David is a professor of the Department of Psychiatry in the College of Pharmacy at Dalhousie University in Halifax, Nova Scotia. David received his undergraduate pharmacy degree from the University of Toronto and completed graduate programs at the University of British Columbia and Dalhousie University. David has worked in the area of mental health for over 20 years as a clinical pharmacist and academic. David has 60 peer-reviewed publications, a new book titled Antipsychotics and Their Side Effects, and has received several recognitions locally and nationally for his excellence in teaching. In 2012, David received from the Canadian Pharmacists Association the Canadian Pharmacist of the Year. David's clinical work is with the Early Psychosis Program in Nova Scotia, as well as consults for people with complex pharmacotherapies for the mental health problems. He regularly provides support group education sessions throughout the year for people with lived experience of mental illness and their families, so that's why he's here tonight. David has been doing family work for at least 7 years, if not probably even before that, but certainly doing the support groups for us here in Nova Scotia. And here you've traveled to Pictou already, and probably other areas of Nova Scotia. David, his wife, Dr. Andrea Murphy, are training pharmacists who work in community pharmacies to move to more directly engage with the communities to improve mental health care. The project is known as More Than Meds. So I'd like to welcome David. Thank you very much for coming tonight. I think you will all find this a very, very informative session.
Well, thank you very much, Donna. It's always great to be here. I look around the room and I feel like we're at a board meeting more so than we are at one of these sessions. So I know or recognize at least several of you, and hopefully I'll get to know everybody who I don't necessarily know that well by the end of the evening. So some of you have had the experience of, I guess, hearing from me and exchanging with me in the past. And you know my style is not a style where I do a presentation and then I take questions at the end. I take questions at the start and use that to leverage what we should be talking about. So maybe I'll ask you guys how your summer was, just to start off a little bit informally, since I didn't know that this was going to be I should have tuned in that this would be the first session, considering it's early September. But what have you guys been up to? Relaxing, taking the sun in, nothing going on?
Yeah, went too fast.
It did.
Not over yet.
No, this past weekend was quite nice. Yeah. We have a little pool in our backyard for the kids, one of those kind of blow-up ones. And July was busy, and then for whatever reason, August, I don't think it got used once. But then this last week, all the friends come out of the woodwork because school's back on, so they were all back in the pool. Don't jump in, you put grass in the pool, but there was more grass than water by the end of one night, so boys playing in the pool. So my summer's been pretty busy. I'm on sabbatical officially for a year, July 1 to next June 30th. And the plan was to be on sabbatical, and everybody's thinking sabbatical means a vacation. Isn't that amazing? That everybody would be okay with professors taking 1 year off every 7 years, and you guys, everybody paying for it. I just think, would that actually happen? So sabbaticals aren't vacations. Our summer was probably busier than any summer that we've had. And in part because of Movember. You guys have heard of Movember, right? And Movember has moved into the area of supporting mental illness in addition to men's health in general and prostate cancer specifically. So if you go to Movember's website, you'll see that they're moving into that area and they've got some initiatives. So we applied for 2 grants and got shortlisted on both, which means that you have to put in a huge grant at some point. So those huge grants went in the middle of the summer, which was pretty awful. We didn't expect those things to come along. So I'll just tell you, one of them is called Headstrong, and it's to go after men's health, and it has to be very masculine and male-oriented. So if we get it, you'll see this kind of headstrong stuff in pharmacies where you see toolboxes, but it'll be about helping men get access to mental health resources through a toolbox. So that was one of our manly ideas. And the other one was a much bigger grant, so much more national in scope, looking at really a ways to wellness for young boys who have trouble with conduct, oppositional disorders, aggressiveness. Because as I think many of you know, we are very liberal these days compared to 10, 20, 30 years ago with the use of psychotropic medications. So antipsychotics are being used much, much more often. Which relates to another thing we did, which was new guidelines will be coming out sometime. I don't know exactly when, it's out of my hands, but Andrea and I were involved in Canadian guidelines for the management of conduct problems, oppositionality, and aggressiveness in children with ADHD and comorbid disruptive disorders. So those are coming out. And just this past month, in August, I wrote an article along with two other articles that were kind of paired together, and I'm trying to remember the name of it. What was it called? Something like, it was a better name than this. The effect of modern psychopharmacology on clinical psychiatry practice. So, a question that I've asked a few audiences in the last little while is, what has been the impact of safer drugs being used in psychiatry? Because in the last 10 to 20 years, we now have safer medications than we had before that. Most of the newer ones, not all of them, but most of the newer ones would be considered, especially in the overdose toxic sense, safer. So what do you think, since say 1990, we've got these new second generation antipsychotics, and we've got all these new antidepressants, and we've really moved into other areas for mood stabilizers. So lithium is still being used, but it has more competition, if you will. What do you think the unexpected effects are of having safer pharmaceuticals?
More often.
They are?
More often.
Yeah, absolutely. What else?
Earlier intervention, I suppose.
Mm-hmm. Who do you think is prescribing them now compared to before?
Of the GPs,
Mm-hmm.
more GP.
Yeah. So earlier, prescribed more often by people who are not necessarily as trained at using them. And what do you think happens to the other treatment approaches? They use less of them.
Get there,
Yeah?
yeah.
So you guys nailed it. That is basically a dividend, if you will, of modern psychopharmacology. We've got newer agents, and you think these are great things, and it is a good thing to make newer, safer agents. And people think, well, that's so good. You know what? I'm not a psychiatrist. I haven't been trained in psychiatry like a psychiatrist. But I'm going to start prescribing antipsychotics. And I'm going to start prescribing mood stabilizers. And I'm going to start prescribing all of the antidepressants. To who are you prescribing these things to? Well, kids, pregnant women, and the elderly, and people in jail. Everybody is going to get it. So our little tight nucleus of we will use these medications when they really need to be used, and because they're pretty scary because of their side effects, we will only use it when they really need to be used, has gone from a ball this big to a ball that's way out here now. And the idea being, they're safe enough, we can just use them that way. And I think most of you know that. I don't think these drugs, any of the new ones or old ones, should be called safe. We should call them what they are. They're medicines. And every medicine comes with its risks. So groups like this, for me, it's always important that people are supporting informed decisions, know your family members, and so you're one step removed from being the decision maker. Some of you have that opportunity at times to have been the decision maker, but it's not an ongoing kind of thing typically. But it's very important to think that when you hear that message, oh, these are one of the newer ones, they're safer than the older ones, right? What happens when people go from driving a Toyota Corolla to a Toyota Sequoia? Do you know what those Sequoias are? Those are the giant SUVs, like one of the biggest SUVs out there. Do people drive safer because they're driving one of those things? There's consequences. You know, people don't necessarily, they may be safer for the people inside that, driving at the same speed as the person in the Toyota Corolla. but you don't necessarily drive it like you're driving a Toyota Corolla. And with these new medications that are safer. So, I always do a little monologue opening up, and that would be my monologue for today. So let me remind you guys.
Perhaps mention the More Than Meds program,
Yeah.
particularly for the
Sure.
Alzheimer's.
Yeah, so Donna, I always have to tell you stuff that you don't know, right? So, I'm going to tell you, who's got a smartphone here with them? Okay, everybody get to, and people online, if there's anybody, some people online, everybody who can hear me, go to bloomprogram.ca.
I've heard of it. I'm not.
The website went live as of Thursday night this past week. So this is exciting for me to have people to go to bloomprogram.ca. So the Bloom program is kind of where More Than Meds has left off and Bloom program has started forward. So for those of you who are a little bit familiar or unfamiliar with More Than Meds, I'll just give you a quick description. About 3 years ago, Andrea and I applied for a grant from Canada Post, because Canada Post had a mental health foundation for a while, and they were giving out grants. And our idea was to help pharmacies and pharmacists, community pharmacists, better engage with their local communities to support people living with mental illness. And so engaging meant actually learning the needs of the people with mental illness firsthand. So one of the first things we did was have a meeting like this with pharmacists from across the province, just a really small number, but they had to come with somebody from their own area who lived with mental illness or who took care of somebody living with mental illness. And they did a training day with us. And then that pair who just learned about each other on that day, got to know each other on that day, because it's kind of silly for me to stand up in front of a pharmacist and say, let me teach you about antidepressants. And let me teach you about lithium, because that's not going to make them a better pharmacist. But if I say, hey, meet Donna. She takes care of lots of people with mental illness. She knows exactly what they need. Why don't you spend a half a day with Donna? They will be a way better pharmacist by doing that than by listening to me and learning about lithium and haloperidol and so on, because they know that stuff. What they really need to know is how can they use that information to help people. So that's really the idea of what More Than Meds was doing, was really trying to pair people who know what the needs are, and people who have some of the information and make sure that stuff is actually working better. So these pairs went back to their local communities and found 5 pharmacists. And what they did with 5 pharmacists was they educated 5 pharmacists on what the needs of the community actually are. And then we asked everybody who got trained to go out and do some sort of support. And this is what, when I've been doing this is sort of the impetus behind it. Like, why don't we have this going on all the time? Donna invites me, I say yes. Why can't we have this thing going on all the time? Because it's really about being here and hearing and exchanging and understanding the needs of your local community. So that's what More Than Meds did. And we got really resounding positive feedback on it. So we went back to the government and we said, here's our proposal to match up with your steering committee strategy. And there was, I think, 61 or 63 in the recommendations component. There were 61 or 63 recommendations. And we did our homework and said, what can community pharmacies support or directly do? And we were able to, I can't remember now, about 25 of the 61 to 63 were within what a community pharmacy can actually support. So we looked at the research in what community pharmacists have been doing around the world and in Canada and the US and elsewhere. We looked at the new strategy and we gave a proposal and they funded our proposal. So the funded proposal is called the Bloom Program, and it's starting with 20 pharmacies. So we've trained 9, and the first 9 are going to be enrolling patients at the first possible date is a week on Monday. Not this Monday, but a week on Monday. So there's 9, and I think there's 2 or 3 in Halifax, but we're going to be training 11 more in 2 weeks. And so we'll have 20 across the province. We'll have a few in Metro, but they're strategically spread out from one end of the province to the other end of the province. And if you go to the website, and maybe some of you have looked it up on the website, it'll tell you all about it. But ultimately, it's kind of like what I talked about, but it's also the major difference is it's about individual patient care as well. So it's not just about getting out to the community, it's about actually caring for the individual. So people will go to a pharmacy after hearing about this, or be in the pharmacy and hear about it. So they might hear about it through the Schizophrenia Society of Nova Scotia, Halifax chapter, Dartmouth chapter, or somewhere else. They might get a pamphlet at the Canadian Mental Health Association or somewhere else. And it might be a physician or somebody else that says, have you heard about this? I think you'd be a great candidate. You need to have a mental illness or addictions problem and a medication-related problem. And that's a lot of people. That's an awful lot of people.
What do you mean by medication problem?
So you're not responding well. You're having side effects. You're not remembering to take it, or you're choosing not to take it. You're on way too many, so we call that polypharmacy. So if you are you have a mental health problem, you're just seeing somebody and you've got a prescription and you're just about to start, don't know if you're having a problem with that medication until you get started. And if it works well, you don't need the extra care of the Bloom program, but for so many people, they do. So if you have been on a benzodiazepine for a very long time, and you want to get off of it because you feel now you're dependent on it. Oh, sorry. Sure.
Thank you.
Then you can go into the program depending on your diagnosis, but you would have a medication-related problem just being on some medications that you don't necessarily need. But it's holistic, as in will help you think about your physical health, your mental health, and addictions if that's a concern as well. Collaborative, you can't do any of this stuff without the health team. And thinking of the circle of care, you can't do anything with the circle of care unless you've got the approval to do so by the individual. So we'll have documentation for all of these kind of things. So it's an actual chart that'll be in the pharmacy. You sit down with the individual, you enroll them, which will be the more straightforward part, and then you set up a meeting for doing the initial assessment. And the initial assessment is you and me trying to figure out what your priorities are. We've got 6 months. So you're in the program for the default of 6 months. You could leave earlier if you want to leave earlier, or if it's important for you to stay in because there's still more room for working together. But the idea is to support recovery and solve the problems that you can solve in 6 months. And that hopefully will bring the pharmacist and that pharmacy team closer to you and your circle of care and the rest of your health team. And after you're out of the program, you'll still continue to work together. It's not like, goodbye, you leave the pharmacy. It's just, let's go back to the regular routine, and you bring somebody else in that person.
So what you're saying is the pharmacists are really encouraging a circle of support, family circle of support.
Yeah.
They're open to that, and
Absolutely.
that's excellent.
Yeah. And so some people say, I don't want my family involved.
That's fine.
And, some of the stuff, like there's a great CDHA document on that says, it's the person's wish, but you can remind them of the value of bringing your family in. So it's not like it's just yes or no. It's a discussion that goes on. So you don't want your mother, or you don't want your wife, or you don't want your sister helping you right now. And then in a month, when you're maybe feeling well or better already. So remember how you were talking about Deirdre and, you didn't really want her involved? Have you given any more thought to that? Because some of the potential benefits of having her are X, Y, and Z. So
There's certain information,
yeah.
That would really help.
Yeah.
Other information, of course, families don't need.
Yeah.
I just have a question. Where did the name Bloom come from?
The goal was it's going to be positive, and it's not going to have any stigma associated with it, and it's going to be connected to nothing to do with mental illness. You know how we're always searching for the right acronym? I'm tired of acronyms. So I don't know where I was, but I was walking along and a Bloom program. And I kept thinking about it, and I just thought, it's, like Bloom always thinks of, new life, right? Moving forward. So it was just trying to be something, and also, if it's too unique, then it becomes a word that becomes stigmatized. Every word we pick in mental illness eventually will be stigmatized. But Bloom's in everything. So you can't stigmatize the word Bloom because it's associated with too many other things. So that's where it came from, just the idea of it. So that's the Bloom program, which is the predecessor of More Than Meds. And if it goes well, which I think everybody's very invested in it, this last 3, 4, 5 months has been an incredible amount of work. We have put so much into the program. It's been days and nights and weekends, and a little team of students and a program coordinator, and we need to think about governance models, and we think about how the government's going to work and what we're allowed to say and do and what we're not allowed to do. And then there's the Privacy Act. So all sorts of layers to making sure that this is as ready to go and as positive as it will be. So
How long is it funded for?
that is a good question. So we've got funding that was kind of like a year, but what if somebody comes in here? You can't cut them off because you're saying it's a 6-month program, right? So what we said is that we really want this to be, bridged. So we will kind of get to hear and evaluate it, give government some information about how it's going, and we hope to see a big infusion to keep it going after that. So we do have a plan so it's not interrupted, and that it is expanded as opposed to just keeping it the way it is. But there's a lot to it. There's Nova Scotia Health Research Foundation's helping us with the overall evaluation component of it.
How does this work with, does this help with side effects then? People having side effects?
Yeah, so if you are taking any psychotropic medication and you're having side effects and you have a mental health diagnosis, that's part of the criteria, and the criteria list is really broad, so it's not meant to just be certain criteria, then you would come into that. Now, the idea is that you're to bring people to the pharmacists, or to bring people in who require your care because it's going to be complex. It's not going to be simple. So if it's side effects for something that I could fix with one piece of advice, I wouldn't be, the kind of person that would be too easy. 6 months of money for the pharmacy for one piece of advice. But for most psychotropic side effects, it's never simple. It usually requires making changes, evaluating how those changes are going, seeing if the side effects are being resolved, seeing if you're losing effectiveness by fixing the side effects, or you're causing newer side effects because you've added in the new medication to help with the side effects of the other medication.
How does this work with their psychiatrist? Are they in on this, or?
No. Well, I'm kidding. So pharmacists work with patients every day, all the time anyway. And this is to engender a better collaborative approach. So you and the patient and their family and their health team. So we've created forms for almost everything that we could imagine they might need. So one of them is how to communicate with the prescriber. Now, hopefully you've done your work beforehand, because for pharmacists to get into this program, they had to fill out a very long application. And before they could fill out the application, they had to do all this work. So it's not easy for a pharmacist to get into this program. The pharmacy itself has to demonstrate that it's done what we're calling an environmental scan, to know all the local resources and actually go out and meet the people who provide that. So to get to know you guys and who are supports in the local community, and get to know the mental health services, the formal government mental health services, and the support groups and so on. So the pharmacists here have met with peer support people, went over to Lake City and toured their area and exchanged pamphlets. So it's that kind of work. So the whole idea is that it's patient-centered and community oriented. So it's just making you better at what you're supposed to be doing anyway. So that when somebody comes in and says, well, have you ever heard of Lake City? Like, why would a pharmacist typically know that? They wouldn't. But at some point they'll be working with somebody and go, I know about Lake City, and for some reason this seems to fit in our little discussion here. And I've got a pamphlet. I've got a whole bunch of pamphlets. So the pharmacy is required to have local mental health and addictions support pamphlets for other groups around them. So that has to be publicly accessible in the Bloom Pharmacy itself. And the forms that we've created are fax off a form to physicians that like faxes to say, Mrs. So-and-so has just entered our program, but you already know about our program because we had to announce it to our local prescribers in advance of us actually starting it. Most physicians will never read anything unless it matters. So I faxed you that form just to let you know about the program months ago. I'm sure you don't remember it or didn't even see it. But now I'm letting you know that one of your patients, Mrs. So-and-so, has come into the, what's this Bloom program? What are you guys up to? What is going on here? We know that it's going to go over very well with some people, and it's going to seem like it's a threat to other people. So I'm just going to keep reminding people, calm down and give it 3 or 4 years and then judge it. Because people will judge it before they see it in action. But I want to make sure that people just step back and say, it's important for us to let this work its way through. I know you're used to making the decisions with you and your patient only, but I want to make sure your patient does well with you. So I'm just wanting to make sure that we're not missing anything. So when I sat down with your patient and I went through that initial assessment, we identified these 4 things. And I just want you to know that we've been talking about that stuff. Great, I really appreciate that. We've talked about it, and I haven't got anywhere when it comes to smoking cessation. Or I haven't got anywhere when it comes to keeping the bowels moving. Or I haven't got anywhere when it comes to remembering to take your lithium. I'd love you to help me with that. Or, well, what can you do? You're the pharmacist. All you do is call me for repeat prescriptions. So we'll just have to see how all of those preconceived ideas of the role of the pharmacist in the different communities with the different physicians will work itself out.
Will the pharmacists or the pharmacies that are involved in the Bloom program be announced on the website? In other words,
Yeah.
I could go, I'd know which pharmacy would be.
Yeah, so when you go to the website, you'll see pharmacies, and you click on it, and there's a map of Nova Scotia with our Bloom flower in the locations around the province. And when you put your little cursor over that Bloom flower, it pops up the location, which pharmacy. And if you click on it, I think you get to see the pharmacist, who's the lead pharmacist from that pharmacy for the Bloom program, and you see the location of it exactly. So you can find it very easily in that semi-interactive map that's on there.
Right. More pharmacists get into the program still, or?
For now, we've got our 20 for this year. So I'm hoping that, in a year's time, we'll be saying, okay, now it's 40. So we're looking for new pharmacies to come on board. Yeah. But we welcome input as in suggestions, or get your pharmacist to hear about it. And because we have an application process, and it's right on the website. So if you are a pharmacy interested in coming in, and it's, what's the word? You just fill out this online form that's expression of interest. So I don't know, maybe after a year we'll have 100 pharmacies saying, we're interested.
I would imagine the success of all this, of course, is dependent on the funding. And how much funding do you have?
So the funding is an estimate because we don't know how busy it'll be. So it's the pharmacy.
Let me back up there.
Sure.
Does the pharmacy receive the same amount of money for each person they bring in?
Yes.
And how much is that?
$75 a month.
$75
Yeah.
a month. So they're not going to get rich.
Nope. No, but the way I see it, your first month's going to be busy with that person.
Yeah.
The 6 months, hopefully, be a 1-visit check-in.
Right.
And so this is a different model of care. So it's not fee-for-service, which is the model most pharmacies have worked on, whether it's a dispensing of a medication fee-for-service or I will help you with a medication review, a one-time shot, I get a certain amount of money for doing that. So we're studying how much time pharmacies are going to be spending with people, and in a year's time I'll be able to show you the map of time and how much effort was made, and hopefully I'll be able to break it down by diagnostic features of the patient and age and region, and maybe even to know that some pharmacies were giving some patients 3 times as much time as another pharmacy. You know, it'll be quite interesting to see what we find out.
And will the evaluation process include the patient as well, feedback from the
Yeah.
patient?
Yeah, so this is the interesting part of the Privacy Act, the new Privacy Act, is how do we get that feedback? So we've got our wording on our forms that meets the privacy terminology that's acceptable. So people can give spontaneous feedback by finishing the program. Upon discharge, we're asking that you sit down with the pharmacist after 6 months and review on paper, you identify what the problems were that you had,
Right.
and what was done, and what was the outcome. And the outcome is just basically a scale of got worse, didn't change, got a little better, a moderate amount, or a lot better, like resolved. And it's you and me figuring out how to fill this out. I don't want to say, I think you're better. I want you and I to jointly discuss how you're doing on that. So that's one way to evaluate it. But at the end of that one-page form, when I say, thanks so much for being in the program, I hope things go well, I'll see you next week when you're back in the pharmacy. At the very end, I should say that you can do a survey. So go to the website and you can fill out the survey, or we can print it off for you.
Yeah.
Or can I check this box to say that you will let somebody contact you in the future to invite you for an actual interview.
Mhm.
So that's where we'll be at the first years doing that kind of stuff. Yeah, see how it goes. Down the road, once we've got a lot more people through the program, we will do that anonymized database kind of study to see if there's any impact on visits to hospital, to the emerge, inpatient stays, and that kind of stuff. So we'll do more of a health resources study on that. But early days, we can only look at things that change early. Yeah. So anyway, that's the Bloom
And I
program.
suppose you can only hope that you're pushing them past their limits of funding. I mean, that would be a sign of great success, I would think, if you have so many people enrolled that it's.
Yeah, so it's up to them how much money they want to give us.
Yeah.
So they will have a ceiling each year as to how much they give, and then we'll have to figure out how many pharmacies for how many people. So here's the funny thing about pharmacy is that do you let every pharmacy have one person?
Yeah.
Or do you hand pick, which means there's winners and losers, I guess. Not everybody wants to be involved in it, but do you hand pick and say, you know, if you can take 20, then you and your staff will get really good at this.
Yeah.
If you pick 4, there'll always be oddities. These will be the odd person in this one unusual program. So it's kind of a tricky thing to figure out. How do you expand it? But if it does show that it's doing very well for patient quality of life, and even if it looks like it's saving money, then the expansion shouldn't be much of a challenge.
Are you attempting to get funding from any other sources?
So far,
Down the road.
we have attempted for the evaluation for other sources, and I don't think people get it. So we've had no luck getting funding for the evaluation part just yet.
Can the contact with the pharmacist be initiated by the person who's taking the psychotropic drug?
Yeah.
Even though it's not their pharmacist?
Yeah, so if somebody wants to go to that pharmacy, so they need to have that become their pharmacy.
Okay.
So it just makes sense that it's your patients in your pharmacy. Now, if somebody says, so you're in this what program? Oh, that pharmacy is running this program called the Bloom program. Oh, really? Well, maybe I'll go there. So that doesn't make pharmacy to pharmacy all that happy because you're moving patients around. But in fact, that's what pharmacies try to do is get patients to be their patients, right? So it is a retail environment and they're trying to do the best that they can.
Yeah.
It's not to make pharmacies rich though, so I'm not sure if there's gonna be a lot of upsetness when people do move around a little bit. But, yeah. Yeah, and it's self-referral, so a physician, a social worker, a mom, a cousin, or the person who's interested in joining the program can do it themselves. Yeah. So that's the Bloom Pharmacy. We're gonna train the next group, and then Andrea and I and the kids are going to Australia and New Zealand in December. So I hope it goes well. I'll come back in a few months and see how it goes. Yeah, so we'll be doing some work with some like-minded people down in Sydney, Australia while we're gone. So it'll be quite exciting. So what else can we talk about? I've been not answering any questions that you've actually generated. So
There was one question online that it really just follows up to your initial discussion about medication and safety and how medication in a way has become more safe. So the question is Dr. Gardner familiar with the book by Robert Whitaker, Anatomy of an Epidemic? What do you think of it? Is the information in the book valid?
I'm not. So now we need to type some more. Or does anybody else here know that book? Anatomy of an Epidemic.
I've heard of it. I haven't read it.
Okay. Somebody needs to Google it. Anybody got their phone handy?
I have a question about clozapine.
Sure.
The totals, the serum levels can change quite a bit from month to month. Is that normal?
I think the answer is yes, but it doesn't mean we know why. So and I'm not going to answer it with clozapine specifically. I'm just going to say clozapine is one of several psychotropic medications where levels are not as predictable as we would like them to be, and sometimes we're quick to say you're not adherent with it, but I think it's quite hard to know what causes things to change. So we do levels on, let's say we have 20 to 30 commonly used medications in psychiatry. We probably do levels regularly on just say 5 to 10 of them. And there's very few where we could actually say that the levels mean something clinically and that they should be steady. And really the only one is lithium that falls into that category. But when it comes to antipsychotics, there's been studies on quite a few trying to figure out what's the right level in the bloodstream. And none of them have come out with robust answers. For you, it looks like it needs to be really high, and for you, it looks like you don't need that much, and nobody understands why. It's quite complex.
There's been a spike in the levels, and then it goes back down, and then there was another spike that was pretty high.
Right.
30%.
Yeah. So I would be probably coming off a little too strong if I said it can be due to this or due to that, because there's probably more things that we don't know that cause it than the things that we do know. The one that's the best studied is cigarette smoking and clozapine levels. So,
Not applicable for this.
no. So,
Dark chocolate,
yeah. So we think about other medications causing interactions. And, when you shake your head and go, well, nothing's really changing. There's no new medications being brought in. There was no intercurrent upper respiratory tract where you had to take an antibiotic that could interact, Then we just kind of say, what does make us do the thing? Our body systems do the things that they do.
allergies. We get allergies.
And is it intermittent use of medications
Yes.
for the allergies?
Nasonex.
Yeah.
That one's
Yeah.
might have gone up then, yeah. Nasonex was used for a couple months, and the serum levels spiked. It's off of Nasonex, it was only on for 2 months. It's ready to go back on, should be only 2.
Yeah.
Really needs it, but, and the oxygen level was down for the last
Okay.
But also, it's given at 5:30, and blood work's taken at 7 in the morning, and changing policy took his medication at 7 p.m. or 7 a.m.
Right, yeah,
And that might make a difference.
yeah,
to
it
him.
would, it would.
So,
Clozapine has a bit of a short half-life, so I would like to get you guys to be mini pharmacologists by the time we leave. So when we do teaching of first and second year pharmacy students, they will learn about how drugs enter and leave the body. So this is, if you're in chemistry, that'll become a concentration symbol. So you ever see that in the future?
I'm
Yes.
gonna ask you to move that.
Bring that
forward.
up?
Yeah,
Okay, sure.
be great. A little closer, perfect.
Good. Okay.
You
So,
got enough room there.
oh yeah.
Yeah.
So when you swallow a pill, it takes a while for it to get into your bloodstream. If you take the medication by injection, then it gets into your bloodstream right away. So you get different profiles. But most pills that we talk about, you swallow, and you don't start at 0 unless it's your first dose. You're taking it after you've eliminated some from the day before, so you have some concentration. You swallow it, and then it peaks, but while it's being absorbed, it's also being chewed up and eliminated, so there's a bit of a competition going on, and then eventually the elimination wins out, and then it does this kind of long, slow decay. So you guys know about decay or those kind of curves in physics? Maybe a little bit. So it's not going down like this. It goes slower and slower and slower and slower. So we call the time to half the amount the half-life of the medication. So if this is the peak, we go, okay, that's the peak, so where's half? Half is about right there, isn't it? So how long does it take for the drug concentration to get here? It takes this long. So that would be the half-life. So if that's clozapine, let's say that's 10 hours. So if you take clozapine at what time?
5:30.
5:30, but then you change it to start taking it later at night, but
7 at night, on the night before blood work for at least 2 or 3 months.
okay,
New doctor.
right.
Um,
So that would account for some difference. And the shorter the half-life, the more of the difference. So if you take your dose at a slightly different time, you might have a slightly different concentration. Wouldn't dramatically cause this peak level to be double. When you say it went up, it's
3,700 to 4,700.
okay. So it went up from 3,700 to 4,700. So I always kind of think of it in percentages. So that's 1,000 over 3,700. So that's about a 30% increase. Is that what you said?
What she said.
Yeah.
Yeah.
That's about a 30% bump up. So it's a good question. Is it in part what we were talking about, the change in timing, and then a couple of other things coming into play that we don't know what exactly is going on? And is a 30% difference clinically important? And the only way to know that, like for clozapine, it's not clinically important as in it's really dangerous and you're going to get serious toxicity from that. You're not going to get that. But you might get new side effects. So if you're a little drowsy, you're going to be more drowsy. If you're a little dizzy, you're going to be more dizzy. But if this happens, there's a chance that you wouldn't even notice it.
Yeah, there were some times like getting up quickly,
Mm-hmm.
very dizzy, like really light.
Right.
Had a few of those.
Yeah.
And always tired anyway.
So clozapine is one of these medications where the level is kind of important for, you got to achieve a minimum amount for it to be effective. But there isn't a clear threshold for toxicity. You know, it's a kind of there's a gray area, and then a darkening gray area, and then a really dark gray area, and then really dark before it gets black, as in that's really too high. But when is it too high? Well, you've got to really see a dramatic amount. So not a 30% increase, but maybe a 230% increase, we would start to say, what the heck is going on here? How did that happen? But a 30% change from 2 levels would be super common in clozapine levels, with lots of drugs actually. So, you know, I was saying before how lithium has a very tight range. It's not uncommon that I get the exact same question from clinicians and patients and family members that say, so what will cause the lithium level? He says, or I swear I am doing everything the same. All right, I go through the list of questions. No, none of that has happened. And I go, well, maybe your kidneys are working better right now compared to they were 2 months ago, and nobody knows why. And they'll go back to their normal self in another week or 2. So just these kind of things happen, and I can't necessarily know why.
I have a question, clozapine again. Our son has been on it probably 4 years. 4 or 5 years, yeah. He's definitely had a dramatic weight gain. And he's developing like the muscle twitches.
Okay.
And also has the getting very dizzy getting up. And just
Can you guys show me a muscle twitch?
actually, it's usually just the arm.
Okay.
And he can
In his head.
Oh, that's true, yeah. And I mean, if he thinks about it, he can control it.
Okay.
But it is, you know, very noticeable.
Yeah.
When he's not concentrating on it. And, you know, I've heard that that is a side effect, and it can be serious if it keeps getting worse.
Mhm.
So I want to know, at approximately what point is this really dangerous for him?
Sure. So the reason I just wanted to get an idea of what it looks like is what one person calls a muscle twitch could be many different things.
Mhm.
So seizures are the first thing that we should think about just to make sure that it's not seizures. So clozapine, as the levels go up, the seizure threshold goes down, which means you're at higher risk of having a seizure with clozapine. So of all the antipsychotics, clozapine has the strongest effect on lowering the seizure threshold. So our recommended dosing is maximum of 600 and an absolute maximum of 900. But we know that around 600, that the risk for seizures in everybody's mind is pretty high. You know, when we kind of walk into that dose, knowing the risk is probably 1 in 20 people will get seizures. Now, that's the dose, but it probably relates to the actual concentration in the brain. And this goes back to the question before, you know, how much causes problems or how much is effective? And we all have something called the blood-brain barrier. So our blood takes everything around, including drugs. And once it gets up around the brain area, there's blood vessels all around. And the blood vessels are quite different up and around the brain. They have a barrier that they don't have when elsewhere in the body, and it's a barrier that keeps things from going into the brain as easily as it would leave the blood vessels and go into the muscle or the stomach or whatever else, the lungs. So up in the brain, you have to have the ability to get through the blood-brain barrier, and all of the psychiatric medications do, because we need psychiatric medications to get into the brain. So once clozapine gets into the brain, it can affect, just like many medications, that risk for seizures. So my first question to you is, what do these things look like? Because myoclonic jerks kind of look like what you just showed me, which can be an early indicator of changes in that EEG, you know how people look at the EEG to see the brain waves, to see if there's epileptic activity or seizure activity as a measure. So you can see those on EEGs. Now, you could also show me exactly what you showed me, and it can be a tic. So a tic is very different, and a good clinician will ask the right questions and say, is this a tic? Is this seizures? Is this a late onset other kind of movement problem? So you know how the antipsychotics can cause late onset movement problems. like tardive dyskinesia and so on, which is really what clozapine does not do. It's a really low chance that it's going to cause that. I really don't, in my years, have any experiences of patients getting tardive dyskinesia or tardive dystonia with clozapine. It's usually the drug we go to when people develop that, and they can let that go away over time while still taking clozapine. So my first thoughts are, is this a tic or is this potentially a seizure problem? And if you can control it, that sounds like a tic. Because tics are something we can suppress when we have to. So I bet you everybody in this room knows somebody who has a tic. You know, the nose or something, right? There's lots of people that just have tics, blinking kind of tics. And people who have those kind of tics, they're very happy when they can just let themselves have their tics. But if they go into a meeting, gonna try and get a job today, gonna control my tics. And when the meeting's over, I'm gonna have a whole bunch just to get caught up.
Yeah.
So it's interesting. So tics are said to be like related to this internal drive to let it out. So something builds up inside you that you're aware of, almost like anxiety. And you tic, and it just relieves that tension, and then it builds up again. So tics are very often treated without medications, often because it doesn't really matter that you have a tic. But for some people, they can be functionally disabling, so there might be cognitive behavioral therapy and certain types of medications, and then sometimes antipsychotics are used as sort of a second-line treatment for the treating of tics. So can clozapine cause that? It can probably do it in different ways through different mechanisms. The first one I would just want to make sure is that it's not related to seizures. So people can live with the occasional myoclonic jerk, and it's not actually going to lead them into having seizures. It's not like it's going to be toxic over time and develop seizures. It's just one of those side effects that they get, and it may actually relate to a slight change in EEG activity that's manifesting as that. But will they develop seizure problems? No. But might they if they went up 100 milligrams more or 150 milligrams more? There's always the possibility that that could happen. Do you know your son's dose?
I think it is between 600 and 900.
Is it? Okay. So it may.
He takes it twice a day.
Okay.
Maybe it was 4 and 2 then, or 6,
Yeah.
but maybe it's 6 and 3,
Yeah. So when it gets into that range, we know that seizures are common. So I use the word common to mean 1 to 10% of people. Other people think when I say common, it's like, oh, everybody gets it. But common is 1 in 100 to 10 in 100. So that side effect would be called common. The seizures would be called common, but it doesn't mean that it's toxic or it's going to cause, so you know what I mean when I say a full tonic-clonic seizure? You fall to the ground and the body goes really stiff for a few seconds, half a minute, and then the big shakes occur. So there's tonus and then there's clonus, tonic-clonic kind of seizures. So those are the ones that we're very concerned, because if they happen, you could really hurt yourself when that occurs. So a good history to take is, has your son ever had a blackout that he knows of?
Well, actually, just the last few weeks, I should say probably the last 6 months, he's been saying that he's, he goes to get up and he's really dizzy. And
Okay.
he said just on Sunday that he had gone underneath the desk to get something, and he said he felt like he was going to black out.
He was lying on the floor recabling something.
Yeah,
when it happened.
yeah.
So he was lying down.
Right.
And he got dizzy, motion sickness.
But
Okay.
it does seem to be getting,
Okay.
it seems to be occurring more
He's
often.
also going to the clinic on Wednesday, so we'll
Okay,
be
so
able to bring some of that up.
Yeah, absolutely.
Yeah.
So the dizziness is a separate thing. And so pharmacologically it's separate. So I've talked about the effect of it on the seizure threshold at a higher dose. The dizziness is actually related to what it does to a different set of receptors in our body. So I usually like to try and bring it up related to something we're familiar with. So there's an older class of medications for blood pressure. And when we talk about a lot of medicines, the medicine goes in and blocks a receptor, where the normal thing that comes in kind of goes up to that receptor, knocks on the door, and something happens. So everybody here has heard of adrenaline, right? So we have adrenaline when we get super excited, but the thing that really mostly takes care of us is something called noradrenaline. You guys heard of noradrenaline? It's part of what we call our fight or flight system, our sympathetic nervous system. So alpha receptors, and just because I want you to be Greek as well, there's alpha receptors, there's alpha 1 and there's alpha 2 receptors in our body. And then there's beta 1 and beta 2 receptors. So our heart and our lungs really rely on these receptors for responses to the physiologic stuff that goes on. So who's had a scare and their heart all of a sudden takes, a few seconds. It doesn't happen right away. You get that scare, and then a few seconds go by, and then all of a sudden, boom, 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 boom. I like that moment before that started, but it just takes a few seconds. So you get the scare, you get the release of adrenaline or noradrenaline, and it goes to one of these receptors. So we often draw a cell like this, and it's got these little receptors, and then adrenaline floats along and binds to it, and then sends a signal. And then the signal is, hey, the heart rate's way too slow for that kind of scare. It's got to really speed up. So that's beta 1 for the heart, and beta 2 is for the lungs, opening up your lungs so you can take a lot of air in. Anybody here have somebody with asthma, and they take the inhaler? You take the beta 2, and it goes, oh, your lungs really open up because it stimulates those receptors to cause a physiologic response. So with alpha, it's also to do with noradrenaline. And alpha 1 is, whenever somebody will stand up here today, your body senses it, that you've gone from sitting to standing. And your blood needs to stay where it goes, right? So it's got to continue to go to your heart and your kidneys, but most importantly to your brain. So what happens to your legs? The blood vessels in your legs will clamp tighter to make sure the blood's going higher. It doesn't have to be so clamped tight right now. So alpha 1 is really important. You get noradrenaline binding to alpha 1 receptors to have that happen. But you put clozapine into the system, and clozapine goes, I kind of like alpha 1. I just like hanging around it. And when it does that, your noradrenaline comes along and goes, oh, did you get out of the way? Oh, the person's starting to fall down. I really got to go in and help the alpha 1 be stimulated. So clozapine is called an alpha blocker. So it blocks alpha receptors from receiving noradrenaline from little simple things like standing up. So when he was lying down doing all the wiring, his body's going, hey man, I don't need anything clamped down. I'm just comfortable down here, prone on the floor, doing a few things. And he did something where his blood started to pool. Not in his brain, but down below his brain. And going, oh, I'm starting to feel dizzy. So that's what happens when we start to lose that quick response to alpha 1 from noradrenaline. And so when we see patients starting out on any of these kind of medication that has alpha 1, we say, by the way, this is the classic pharmacist. And by the way, when you start taking this, you'll have to get used to it. When you stand up in the morning, sit on the bed, and then put your hand on the side of the bed, and then wait 30 seconds, and your body will catch up, and then you can go. But if you fall, you just fall under your bed and go, oh, good thing I didn't go away. So the higher the dose of something like clozapine, the more it's going to be interfering with noradrenaline's effect on taking care of us when we go from one body position to another body position. So it's a pretty simple thing, and we don't think of, oh, this is a devastating side effect. It's just devastating when you fall and smash your head because you're blacked out. So you can have blacking out for alpha 1. You can have blacking out because you've had a seizure, which is a completely different kind of blacking out. And you would probably wake up with a very different experience physically. After you have a seizure, you feel awful, super tired, disoriented, not knowing what happened to you. Alpha 1 is faint, basically somebody fainted. So when you faint, you often wake up going, I know exactly where I am, and how did I get down here? I've lost a few seconds of my life, but there's not so much confusion. So it doesn't sound like he's had an actual fainting spell.
No.
But if he did say he blacked out, it's like, is it fainting from this alpha stuff, or is it seizures and you blacked out because of seizures?
So is there anything to counteract those other than just taking time when you're?
You know, like you could say when you see a psychiatrist visit is,
What, in September?
Uh,
Not this September.
you see a prescriber?
The psychiatrist?
Yes.
Yes.
Yeah. Somebody who you could ask because if it is above 600 and there is myoclonic jerks, it's fair to say, would you, if this was your son, get an EEG at this time?
Good for you.
And then they'll say, here's my rationale for yes, or here's my rationale for no. But you've put a fair question out there. So a lower dose will have less of the dizziness related to the postural changes, and a lower dose would have less chance of causing seizures. And therefore, if these jerking moments are actually myoclonic jerks as a predecessor to a seizure, then that would come up potentially in the EEG. And a lower dose would reduce the chance for that. So it's easy for me to say the words lower dose, but the decision to lower in a dose is not to be taken lightly.
It's just wonderful to find out what
Could be going
it
on.
means
Yeah.
when that actually happens.
Yeah. But the other thing is to ask them about tics. You know, when you do it, you kind of feel it building up in you, and then when you release it, it's gone. And that would have nothing to do with the medication.
Is that when they use, is it lamotrigine?
For
For seizures? Is there something they use?
Yeah, so we don't advise people to take seizure medication to prevent like clozapine-induced seizures. Only if seizures occur, then we can put the person on a seizure medication, an anticonvulsant medication, like lamotrigine would be a very typical one that we would use. So that happens on occasion. How are we doing? Any other questions to come along?
I have a question from someone online.
Sure.
How long are drugs tested before going on the market? And do side effects develop after long-term use?
Okay, so the first question, how long before they get on the market? And the simple answer is not long enough. The second question, I'm not clear, is it certainly people who take medications for mental illness can develop late onset side effects. So I'll answer these in a little bit broader terms, but if there's a follow-up clarity on the second question, is it to do with staying on a medication long term?
I would hazard a guess that it would mean, would there be side effects showing up that didn't show up in the drug trials?
Yeah,
Showing
okay,
up
'cause that's
after-
what I wasn't quite
After
sure.
10 years,
Yeah.
you can't test a drug for 10 years, so
Yeah.
after 10 years, are there things that are showing
Yeah,
up?
okay. So let's do just a real quick look at how drugs get to market. So there's preclinical phase 1, 2, 3, and 4. So pre 1, 2, 3, 4, and then PM for post-market. So clinical trials means trials in people. The word clinical is people. So preclinical means trials in animals and test tubes and other things that are not people, like actual mixtures of cells, just to see what happens to the cells. So these ones will go on the whole time. And the phase 1 kind of studies could go on for the whole time. It's not like they're this long and then they end, but this is where they start, but they can continue on. So this one, phase 1, is just the first human studies. Could you imagine? We'd like you to come in and take a drug that no human has ever taken before. But in animals, it looked pretty good. Like that. There's some people that that's the only way medications actually get to market, is they have to, every single one of them. And they say for every medication that gets to market, about 1,000 have got to phases 1 or 2 and didn't go any further. So there's a huge amount of failure for any one medication to actually get there. Phase 2 is actually looking how the medication works in the people who would take it. And phase 3 is the bigger study of phase 2. So if this is a medication that you think is an antipsychotic, by how it works in the preclinical work and some of the pharmacological studies done early on it, then you'll start to actually ask patients to take it in phase 2. And then phase 3, you will actually do the big studies. So most of the studies that are done in the world kind of go to the FDA first. Canada always likes to let the FDA make a decision on things. So the Americans will see drugs that have been less studied than the Canadians. I am fine with us waiting a little while because there's very few medications that are breakthrough, tremendous, wonderful medications. So I would rather wait and know more safety information about a medication. So phase 3, FDA, I'll just talk about the US, the FDA, their kind of rule is 2 positives and you get the nod. So if there's 2 big studies done, and big could be in psychiatry, 200-300 people. If 2 of the studies come out better than the alternative, now the real question is, what's the alternative? What should we compare these medications to? And very often it's nothing. But the standard of treatment is often not nothing. So sometimes it's you compare this medication versus placebo, or you compare it with standard treatment. Now, how would you do a study where you're saying, like, let's go back a while and say, all right, clozapine, not on the market, compared to the standard. So the standard back then might have been chlorpromazine or haloperidol. So if you compared it to nothing, it's people with schizophrenia on no medication, you might look pretty good. But if you compared yourself with an actual active medication, you might look pretty bad. So you'll need to be compared with both, but ideally you want to at least look equal to or better than the standard of care. So now we get confused. Do we do a direct comparison of chlorpromazine versus clozapine, or do we do everybody gets chlorpromazine and you add clozapine and you add placebo? And that gets pretty hard to figure out what's the right thing to do. 2 antipsychotics versus the old antipsychotic to see if adding one helps versus this kind of thing, clozapine and chlorpromazine. But what if they both didn't work in the study? Then they'd look equal and you'd think clozapine helps. So then they sometimes do this: placebo, clozapine, chlorpromazine, and clozapine, a 3-way study. So I know I'm being kind of long-winded in this answer, but it gets really murky here. And if all they've done is a couple of these studies, 3 of these studies, 5 or 8 studies in people with schizophrenia, but they don't have comorbidities and they don't have problems with drinking or pot smoking, they're unique. They're not typical, if you will, of the kinds of patients that are treated in clinics. But that's where the rubber hits the road. We have this much information, before a drug comes to market. And it varies, but that might be 10 to 20 years of information. It might be less than 10 years of information. So how many people are typically studied in these trials before the drug gets to market?
Less than 1,000?
It's probably around 2,000. Not all of them are getting the active drug though, because we've got these other groups.
Right.
So that's not very many people in my mind. And the studies for a lot of psychiatric medications are to determine if they help in the acute phase. So antipsychotics, you'd probably be a bit disturbed by it, but if I showed you some of the early work on any antipsychotic before it got marketed, I could show you a lot of 6-week studies, 12-week studies. And then they did the long-term 1-year study in 80 people or something like that. So it's dramatically small in terms of the proportion of people who are ever exposed to the drug before we say, or we have our regulator say, safe for the masses. And then, to go back to the second question, we get the post-marketing data that means, hey, when we use it in everybody who are on a whole bunch of other medications that have never been exposed to in the preclinical trials, who have a whole mix of issues going on, who are taking more than was ever studied, less than was ever studied, it combined with other things that were never studied. We definitely get lots of new information. So the companies are told to do post-marketing surveillance, and it's really inadequate. You just keep your eye out for any bad things by conducting this study, and they'll come up with it. We're doing a longitudinal study called the Horizon Study. Ooh, that sounds good. What's the Horizon Study? Well, we're looking at a bunch of patients on it. And how many people? Oh, a couple of hundred or 300. Oh, that sounds like a lot. But when you say 300 and 1 million are being exposed to it in the first year or two, it still really feels inadequate. So once a drug comes to market, the government really has very little teeth currently. The legislation can be changed, but that's not the way it is. There's changes afoot in Canada, and I'm trying to remember Jessica's Law. So Jessica's Law was, I think, put into maybe the first reading or something like that, I think before the Parliament ended it for the summer. And Jessica's Law was based on a lawyer, I'm trying to remember the dad's name. He became an MP. I remember sitting at a table with him a long time ago. His daughter took a medication for heartburn when she was a teenager and died because it caused an arrhythmia, and it was known at that time that it caused arrhythmias. So, you shouldn't die from taking a medication that is for heartburn. And so there was already quite a few deaths accumulating, and his daughter was the last one to die before the drug was whipped off the international market. Lots of lawsuits and so forth. So the law that this MP lawyer has put forward this bill to give the government more teeth, so that instead of paying a very small fine for continuing to market a drug when you know about its serious side effects and not telling people about them, all these different things that can be done, to go after them with big dollars and cause huge dividends to the company because of those kind of practices. So you might hear something more about it. I don't know where it'll be when Parliament comes back to the House. But that's one, I guess, thing that may change some of this post-marketing surveillance and how companies actually do that. In the US, there's something called, I can't remember the full term, but it ends with mitigation strategy. So when companies find out they've got a real side effect that seems new and unexpected, they have to come up for the FDA and say, here is our risk mitigation strategy for that side effect, and deal with it in this kind of way. So I learned about this by when I was looking into the long-acting formulation of olanzapine. So most of you here are familiar with Zyprexa. that medication, olanzapine. So it's available as a pill, as a sublingual pill, or a melt on your tongue kind of pill, or you can get it as a short-acting injection, you know, to help for agitation or aggressiveness in the next few hours or something. But they also formulate it as a long-acting injection. And everybody's familiar with the long-acting, or depots that we call, for the management of schizophrenia. Once every 2, 3, or 4 weeks you get an injection. So olanzapine was in the US, and I think it's available in the US as this long-acting depot, and I'm trying to remember its brand name, Zyprexa. I can't remember its actual long-acting name. But anyway, I think, was it before it got marketed or shortly after, a few cases came out of people becoming basically comatose within a few hours of the injection. So when you make a long-acting injection, you have to make the medication leave the muscle really slowly, because you put 2 weeks worth of the medication into the body. And you can't just have 2 weeks worth get into the brain. So I think what happened there is that sometimes it wouldn't get into the muscle correctly, or it might get too close to the bloodstream and get into the bloodstream. But there's usually other safety mechanisms, as in you take the molecule of the drug and you add a second molecule that's really long. And those, when they're long like that, they don't get into fat easily because they're aqueous liking, so they wouldn't go into the blood-brain, through the blood-brain barrier easily. And it takes an enzyme to come along and cleave that, so that slows the process down. So that's what it is with many of the long-acting injections. So I'm not sure about the formulation for this olanzapine. But a number of people went to their clinic, got their injection, and on their way home, passed out and were found cold. And I think there may have been some deaths associated with that because of the medication. So you go to the FDA's website is an amazing thing, because you can see lawyers speaking to each other. They're very open about that. You can dig into their archives and just read how they, well, thank you for that information, and we will go, you know, all this lawyer kind of speak, but when you actually think what they're talking about is
Which website is that?
the Food and Drug Agency's website. It's a very dense website, like to get all around.
You don't find a way around that?
But you can. They have all these dockets, and they show all these communications with drug companies, and you can read what they're telling them that they need to do and so forth. So anyway, they had to come up with a mitigation strategy. And the essence of their mitigation strategy was, we will not let anybody get our drug unless they plan to stay in the clinic. So the places that we will give our drug to will have clinics where you sit for 3 hours. So their mitigation strategy is that you're not allowed to get this injection and leave. You get it and you stay for 3 hours, which is kind of like nobody's gonna prescribe that. So I'm sure it's still available in the US, but I bet you very, very, very few people are actually prescribing it. So that's the post-marketing surveillance stuff, dealing with side effects that you would never have seen coming beforehand.
Doesn't help if Canada have an adverse effect monitoring program?
Yep.
How does that work, and is it effective?
No, it's definitely better than nothing, but it's very hard to come up with something comprehensive without being overwhelming. So if you ever did want to look it up, it's called Canada. En français, it's Canada Vigilance. We don't say vigilance, we say Canada Vigilance. So that's our sort of overall program. So I can call them up, or I can go onto the website and say, give me a report on how many people have taken ziprasidone, the antipsychotic, in the last year and have had, and I can ask for mortality numbers due to cardiac problems. And so I can get that kind of stuff. Now, here's the problem. If somebody gets ziprasidone, which has been for a very long time a concern, and I'm not saying it actually is more concerning, but for a lot of people it was thought, is it more concerning about arrhythmias? So you've got a drug that keeps just about getting on the market, just about getting on the market, and just about getting on the market. And all these years of waiting, why are we waiting? Because we're concerned about arrhythmias. And then it finally gets on the market, and you give it to a bunch of people, and a few of them die from arrhythmias, what's going to happen?
Lawsuits.
Lots of spontaneous reports, because that's how it works. So you get a whole bunch of people saying, oh my goodness, I better write this up. So you go on the website and you write it up and you send it into Canada Vigilance and they go, oh my goodness, in the first 6 months we've had 131. And then another medication comes along and it's Abilify, aripiprazole, and nobody's talking at all about arrhythmias. And there's been no waiting and no concerns about it. And the same number of people die from arrhythmias. The fact is, that just pretend with my scenario, the fact is the exact same number of people die from arrhythmias. What happens when you die from an arrhythmia? Do you know how it looks? Oh, and I'm down. There's no blood test. There's nothing you can do to see if it was an arrhythmia. I just sudden death. That's how people die from arrhythmias. So these people over here, well, what happened? Well, he grabbed his heart and he went to the ground and he died. I'm writing it up as an arrhythmia because this drug that he's on causes arrhythmia. So it might be he grabbed his heart, or more likely arrive at the emerge. Sorry, we have to pronounce this person dead. Sudden cardiac death, no reports at all. No, that just happens. So the system is flawed because it's all to do with spontaneous reporting. So if I want to look back at the system, like I just said, I can look into the system and see how many people have had certain problems. Then I can tell some information. But it doesn't tell me the rate of that side effect. It doesn't tell me if the drug caused that side effect, which are kind of like the things you want to know. So what does it tell me? It's a system of like warning signals, but not demonstrating or proving causality. So a recent side effect, not a recent enough side effect that's come across my plate that some people, some psychiatrists and others are thinking may be related to quetiapine, Seroquel. People have heard of, everybody knows Seroquel, is its effect on thyroid. So, you know me, I'm supposed to know about drugs. I've never heard about it causing thyroid problems. I've never heard of any antipsychotic causing thyroid problems. So I just never thought about it. But I guess there's, in looking into it, there's a very small number of case reports of people who took quetiapine and developed thyroid problems like hypothyroidism. Did the quetiapine do it? How would we ever know? You'd think it's easy, right? Until I actually ask these questions to you, it's really hard. So who gets hypothyroidism? A lot of people get hypothyroidism. Women more than men get it. Women in their middle years, women during pregnancy, women who are 40, 50, 60, all of a sudden their thyroid's not working. Men get it too. And what do? They get a blood test, and oh, your thyroid's not working, go on this thyroid pill to replace the missing thyroid. It's really straightforward. So it's a common thing. Now, what about quetiapine or Seroquel? Is it commonly used? It's another common thing these days. So you put two common things together, eventually you're going to see a few thousand people with thyroid problems also on Seroquel. So it's going to be really hard for us to figure out unless we can get some sort of biological data showing, and this is next to impossible, quetiapine interfering with thyroid functioning. So there is, from the previous page, some preclinical data of quetiapine being found in very high concentrations in the thyroid gland next to, what was it called? Not as bad as this, but purple spots. And they say, we don't know the clinical meaning of the purple spots. This is what we know about quetiapine and its relationship to thyroid problems. The good news is it seems to be very idiosyncratic. We can't predict it, and it seems to not happen very often, if it happens ever at all, with quetiapine. So it's one of those kind of things that somebody asked me, David, does quetiapine ever cause thyroid problems? It's going to be impossible to know. But I know way more than I want to know about quetiapine and thyroid problems. And the answer is, maybe. What's next?
Any more online?
I do have one little question. When you're taking an antipsychotic, and when it's prescribed, you've been smoking and drinking,
Mm-hmm.
and you've been on it for a few years, and then you stop smoking,
Mhm.
and then you stop drinking. Should there be some sort of adjustment in your prescription levels?
Is it clozapine?
Yeah.
I would say there's a good chance there should be, could be. So there's, I can never give a straightforward answer, you know that, right? So this is what's happened in some people. They, I was showing you, each day you take your medication, it peaks and then it leaves. Now, people who are smoking while on clozapine, when they go cold turkey, so if this is sort of where it is, this is what's happened to some people. So a dramatic rise in clozapine levels when you stop smoking. And this is what's happened to other people who stop smoking with clozapine. Stop smoking cold turkey, and that happens. So, this is probably the difference why some people go here and some people go here is genetics. So this person the first person had very inducible enzymes. So our livers are what are responsible for breaking down chemicals that come into our body, whether it's through food or what we breathe or what we drink, alcohol and everything else, or the pills that we take. Our livers are, for the most part, breaking them down to help us get rid of them. So our livers do that by these proteins called enzymes. And let's just say the typical is 1,000 enzymes working at a 80%. So if you take another pill, you can induce those enzymes. And that means to us in the pharmacy world, you can get more of them working harder. So that means you're going to be able to get rid of those medications faster. So if you're inducing the enzymes by smoking, because that's what smoking does, it induces the enzymes, then you're going to go back to normal. You're going to slow down and just go at the normal rate with the normal number of enzymes. So if you have less, you can't handle the same amount of medication, so you have to get to a new equilibrium. And so some people have become quite unwell because of clozapine toxicity. And other people, it's fine. Now the neat thing about clozapine, it's kind of research-based, but it's a lot of anecdote too, is that some people say, I'm better on clozapine, I'm not that interested in smoking anymore. And so there's quite a few people that stop smoking while on clozapine. And these are the cases we hear about, but there's a lot of cases that people just stopped and they're fine on clozapine and it didn't change their levels and nobody talks about it, it doesn't get written up in the journals or anything. So yeah, I can't say if it should go down. The other question, or the other part of the question though, is drinking. People are usually less well, less stable when they're drinking a lot. And when they're less well, less stable, their dose sometimes is higher than it would need to be if they're more well and more stable and not drinking. So there's I guess a part of the story is recovery. If you are doing better, you're more stable, your road to recovery is going better, then we often pull back the medication dose, and it often goes well when we do that. So we very gradually take that dose that you were on, you've had quite a long time of sobriety, and then we slowly bring it down little by little, and then we get to here and go, oh, something's not quite right. So we go back up. And then maybe over time again, we'll try that again. Or maybe we'll say, oh, we'll just stick in this kind of range. So it's a pretty typical approach to say, you were way up here, you've done very well for a good long time now, so let's gradually pull that down. So I know a number of people who've been on 450 to 600 milligrams of clozapine, and that seemed to be the dose that got them well and kept them well for a long time. And then today they're on 175. They just were persistent at saying, I really want to try lower doses. Took them, years really to get from there to there, but they're doing okay on 175.
But now, with the system the way it is now, and our son sees the psychiatrist once a year, and these changes have happened in the last year, I would say. Should he book another appointment with the psychiatrist?
So who prescribes the clozapine?
It's the
Psychiatrist.
psychiatrist.
The once a year psychiatrist?
Yeah.
Whether you need him or not.
Let's just extend this out to every 5 years. Come on, really. So,
Now, he does, like, he goes every month to, to the clinic to get his blood checked.
Yeah.
And he has mentioned these things to the nurse there.
Yeah.
That he stopped smoking and, the cutting down the drinking has been the last couple of months. So I don't know if he's actually thought to mention it to them or not. But it just seems that it's mentioned, but there's no follow-up, there's no sort of consistency, these changes
So,
are being made.
I don't know, like there's no rules, right?
Yeah.
So he could go in and say, well, I've been doing really well and bothered by these side effects. I'm stable, I've done some really positive things, like this was my history of drinking and this is where I'm at now. I want to cut my dose down. And then she'll, and it'll depend.
Yeah,
But
okay. So
what,
that's-
can I see Dr. So-and-so next month when I come back? It's me, like I'm the one taking this stuff. And I'm moving on with my life, right? Like, do I have to honestly wait a year before I'm allowed to ask a question about the dose?
Right,
That just seems archaic.
I would, you just sort of think that he's in a situation there, he's made some dramatic changes, and that you would think that I forgot, I got.
So what does his list look like?
Oh, points, like make sure you ask him about this, this, and this.
Does he give the list over to the nurse?
No, he doesn't, he probably should, that's a
Yeah,
good idea.
That's what I would do.
Yeah.
So we made this little booklet, as you've probably seen a few years ago, but you don't need the booklet to get the idea. Our idea was, all you need to do is go in like this, write your questions out. This was medication question checklist. So you're just going to go this one's to your prescriber, write the questions down or circle the ones you're interested in. I don't mean to, control the meeting today because I know you have lots of questions for me, but these are my questions for you. So go ahead anyway, go ahead. What were you going to ask me? So now it's there. Like, we can't pretend it's not there. So, well, I do want to talk about these three things, but I didn't realize these things. So let's try and get to as many as we can. And I might change the order of what I was planning to talk about with you.
I think he feels a little flustered when he goes, so.
Yeah, but that's the beauty of the pre-made list, right? So you go in there and you say, okay, so if you guys, would you work with them on the list?
Oh, of course.
Would that be the kind of thing to do?
Yeah.
And then you say, well, like, put them in the priority of most important to least important. So if you don't get to the ones at the bottom, you don't get to them. But put them on there and I like the whole idea of going, let me just turn that one right around for you and put it right in front of you.
And write the answer down too.
Oh, well, yeah.
Sometimes I don't think they know, staff may not have studied as much as family has about, like, the smoking.
That's right, yeah.
They don't realize that.
No.
They just don't know.
You're more than welcome to the David Gardner said, start off with that sentence.
Could you then also have a place just where the person could sign it if they saw it? I mean, I would go in with 2 copies and come home, what's the problem about it? You saw it, and take the
Sure.
copy home.
Yeah.
I mean, it would be enough to say, oh, something's going on here, I'm on trial in a way, in a gentle way.
Yeah.
But it would be
Yeah.
another little nudge.
Yeah. Get your smartphone out. My memory is it's not good. Let me just record this, okay? You don't You could do that and write out your questions on a piece of paper, 1, 2, 3, 4, and then give your photocopy over and, okay, go ahead. Or what did you say? Okay, 175 at 5 p.m. Oh, okay. Whatever the information is. We just forget sometimes that it's not about them. The center is the person that's being treated. And I know. I see the look.
Can I ask one little quick question?
Oh, yeah.
And I'll give you an update later, go back now.
Okay.
I'd asked you once about nasal stuffiness, and the answer was Sudafed.
Uh-huh.
Nasonex. How does Nasonex? Justin seems to think that it works almost immediately on him.
Mhm.
We had a time this spring for a week and a half that I couldn't see him,
Mhm.
and due to things going on, he was doing okay.
Yeah.
And he was put on Nasonex, and I knew that he was on once before for maybe 2 weeks, and this time he was on for 2 months. I mean, I had no input, I had other things going on. Is that okay to be on, or? And it's gonna be ongoing.
I think Nasonex is mometazone, and I think it might be related to that alpha stuff I was talking about.
And no turning
Yeah.
white and pale, getting
I'm going to use my drug information sources. Google. Hold on now. If it tells me. So it is mometazone. All I want to know is how it works. I want to enter the Nasonex site.
nasal spray for nasal stuffiness and allergies.
There we go.
Nasonex, but it, he has allergies.
Okay, I know its chemical structure now.
Right.
All right, pharmacodynamics. It's one of these very old ones, and sometimes they don't know how the old ones work. Oh, it's the steroid.
He doesn't stay on it, they don't keep him on it a long time, but you see significant improvements in alertness and everything because the nasal stuffiness is gone.
Right.
He did super great.
Yeah. So, all right, so since it's a steroid, there's a number of steroids we'll use for the nose and like for asthma. So people said they know about, for asthma, we use that one that opens up our lungs, the alpha stimulant. The one that is to be used every day to prevent an asthma exacerbation is the actual steroid. So a steroid actually keeps inflammation down. So if you can keep inflammation down in your nose, all your blood vessels are narrowed, letting the passages be bigger and the vessels be smaller. So that's the idea how it would work to counteract the stuffiness. But the interesting thing you said is that it works right away. So steroids don't work right away. Steroids take a few days for the anti-inflammatory effects to really take hold.
Well, I didn't see him during those first few days.
Okay.
He was on it,
Yeah.
so.
So that would be the thing about Nasonex or any one of the nasal steroids, which there's other ones, is that it would need to be used regularly. You can't go, I'm stuffy today and take it once and expect it to work. Sudafed, or everybody knows Dristan, that's another alpha 2. So Nasonex is steroid, not anabolic steroid, but corticosteroid, a different type of steroid. So days, and then there's alpha 1 agonists or stimulants, which are that fight or flight system. So it awakens you and it gets you going, but it also makes your nose clear by taking your blood vessels and making them smaller. So they weep less. There's less stuff coming into your nose and making it as stuffy. So that's Sudafed, pseudoephedrine, which is Sudafed. Anybody here ever taken Sudafed? Good for hangovers, good for other things.
It's recommended for babies. It's the only one you're supposed to give, I thought children, that's my doctor said years ago.
To not give.
Oh, no, it was actually told to give that one, not other decongestants for children, because it had only,
No. Anybody under 6 shouldn't be getting any medicines other than Tylenol for cough and cold stuff. So Sudafed, pseudoephedrine, and then what was the other one you just mentioned, which was, I mentioned it, sorry, not you, me, Dristan, oxymetazoline. So all of these will work quickly. Now Dristan is right to the site, so it's pretty much right away. In this one, you have to swallow it, let it get absorbed and go all around. So it lasts a while, but it takes, 15 minutes, half an hour for it to work.
and what can you take long term?
So this is quite fine long term. So we take these kind of steroids into our lungs with asthma for years, and to our nose for inflammatory nose, right, like allergic rhinitis and things like that.
Would it even work like every second day or something like
Yep,
that?
yep.
So
As long as there's sort of a regular exposure to it, because it's, anybody know the bagpipes? Anybody ever play the bagpipes? Like you have a bagpipe here, and you have to blow it up and like a dose. And then it fills up, and then you start to slowly squeeze it out. So if I don't blow for a while, there's still some stuff in there. So it's kind of like you're filling up your body with the medication. And if you have it every second day, it takes a while for it to work anyway. So it's going to take a while for it to stop working, but you're giving half the dose. So you just have to be careful about it. Now you're saying every second day. I would think when you take a medication daily, that's way better than every second day. Is today the day? Who remembered which weeks were the green bin weeks?
Look at
Got a question?
Yeah, we have an online question. Do some people react better to generic medication than others? So I presume that means than other.
Yeah.
I think, do some people react better to generic medication than others? I guess it's other people. Other people. Yeah. Could be also other, the brand name medication.
Yeah.
I'm not sure what they mean.
Yeah, so it's the same medication. So if we, take a pill, and this one's pink and this one's white, and this is the generic version of olanzapine, and this is the brand name version of olanzapine. Are they different? Well, this one's white. Right away they're different. But is there any meaningful difference? So if this one is 10 milligrams, and this one is 10 milligrams, then they have to have exactly 10 milligrams of the medication. So you swallow it, does the pill stay as a pill and come out the other end exactly the same and you don't absorb it, or does it get broken down? What happens? So pills are made up of the active ingredients and the non-medicinal ingredients. And what's different is the non-medicinal ingredients. So this will have some mix of things to make the pill fall apart when it gets into your stomach. And this will have a different mix of things. And the question is, who cares? Does that matter? So Health Canada says you have to follow some rules to be called generic equivalence. So to be equal, you have to do two things when it comes to this kind of pill. So I'll show you. This is brand name olanzapine. You know what I'm doing, right? You swallow it and you absorb it and you start to eliminate it, and that is the pharmacokinetic profile of the pink one, the brand name one. Make sense? Now,
For one person, or is that an average, or?
so
Yeah.
this will be the average in a study of the kinetic profile of it. So you've got a number of people, and that's the average. So then we get the maximum concentration, Cmax. This is total pharmacy school all of a sudden. And guess what this is called?
Tablet.
C-type,
Tmax.
T-Mac.
So the concentration maximum at what time? So this is important. So when you swallow this, you have to be within the average. So going back to the average, has to have, I'll get to the technical definition in a second, but it has to be kind of around the same time and similar maximum. And this is called the area under the curve, which is the amount of drug the body gets exposed to. And that also has to be similar. So instead of getting technical with confidence intervals and means and confidence intervals, this would not be allowed. Health Canada would say, go away and figure out what you've done wrong. And this would not be allowed. But what is allowed is something like this, or something like this. So the area under the curve is within a certain percentage difference, and the Cmax, Tmax is within a certain percentage difference. So we talk about 80 to 100%. So if the mean is of the Cmax was 100, the mean of the other drug, the generic drug, could be 105. But the confidence interval of what's the truth that we're 95% sure could be somewhere between 91 to 114. So this is our range of uncertainty. What's the true Cmax comparison? Well, this is an estimate from one study. And that gives us some uncertainty. So based on our level of uncertainty, somewhere the truth could be in here. So that's all inside that range of 80 to 120. So it couldn't be that this mean could be 81% of what they had. Can't be that low, because the range outside of that would have probably been about 70 to 90, and that means we're too uncertain about it. So people get confused saying, did you know? You'll have people say this, they've read the Health Canada site or heard me talk or something. Did you know that you could take a generic and it's only 80% of what you would really get? That's actually not what it says at all. It's more technical than that, it's just harder to explain.
My daughter went to a generic brand of Webcast this spring.
Yeah.
For maybe 2 months. And she ended up going back to Webcast. There was a difference.
Yeah. So I'm not saying that that doesn't happen. What I'm saying is when that happens, it is always the exception. So therefore, every 100 people that switch over to generic Wellbutrin and don't notice, there will be somebody that said, I did notice, and I did better on it. And the manufacturer of the brand will say, "You don't mind if I tell everybody your story, do you?" And then there was this other guy who switched over to this and nothing happened. Nobody wants to tell that story. So there is a bias towards our concerns about generic not being as effective or being full of side effects. Usually it's the effectiveness question. And there are examples of that where it's true. Now there's some medications that are a little more notorious than others, but the vast majority of medications in the world, not just in psychiatry, but in every area, this is the stuff that's true, and nobody would know any different, whether they're on a generic or a brand. So there are some exceptions, but for the most part, the truth is generic is as predictable and effective. I had a professor once when I was back in my Doctor of Pharmacy program. He says, "Okay, so let's look at that. Now let's look what people do. All right, they forget to take their pills. That's going to change things way more than this. And for some pills, they take too big of a dose or too small of a dose, or they take it with food, or they take it with alcohol, or they take it late at night one night and then early at night the next night." So that's going to make way more differences than any of this stuff. So when we hear about that, those two drugs are slightly different in terms of their pharmacokinetic picture, we make the pharmacokinetic picture way more different on a day-to-day basis than the drugs do. And usually we don't find any difference in that sense.
So, an old lady that I knew got quite upset when the pharmacist gave her the brand name,
Oh, the brand name.
because she'd been taking the generic for a long time, and turned out that the brand name had more food coloring, and the binding agent was
Right.
different, and her
Right.
body didn't tolerate it.
Yeah.
And so she
Yeah.
she said, like, it wasn't.
What is a real problem, what causes, I think, the most concern is exactly the switching without being told. So here's your pills, and you look and go, "I've never taken these pills in my life." It's really reassuring if the pharmacist says, "Oh, that's because this is this company's brand, which looks different, but I can assure you that's actually what we are giving." You don't want to go home and look it up online and go, "Okay," because it can make a lot of confusion and concern unnecessarily when it doesn't get explained to you. Any last questions, final questions? Anybody online?
Well,
Good.
that concludes our
Well, I'm glad we got into some good questions. I didn't want to talk about the programs going on this now, but
Thank you very
you're
much,
welcome.
David.
Okay.
Okay, we'll see you next week. Shut her off.